Started. Good afternoon or good morning, depending on where you're joining us from, and thank you for joining us for Mpox, Where Are We Now, hosted by HCET with presenter Dr. Jason Zucker. My name is Jordan Greenwald. I'm the Training and Community Engagement Manager at HCET, and I will be moderating the webinar today. For those of you that aren't familiar with HCET, or healthcare education and training, our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. We are an organization of passionate people who are proactive in our belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care are fundamental rights. This webinar does have closed captions available. To enable them on your screen, simply click live transcript or closed captioning, depending on the version of Zoom you have. It'll be at the bottom of your screen. You can click show subtitles, and then you can change the settings by clicking subtitle settings. Throughout the presentation, we do encourage you to send your questions via the Q&A box. So to submit a question, you will hover over the main screen, then select the Q&A icon at the bottom. Once selected, the Q&A box should appear, and to send your question at any time during the presentation, please do it through the Q&A, as this ensures everyone in the webinar can view your question, and you also have the option to send your question anonymously if you would like. We also encourage you to follow us on our various social media accounts to keep up to date with the newest information and events. And now I'll just quickly review some housekeeping. A link to complete an event evaluation will be sent to you in the chat at the end of this webinar, as well as via email following the event. Your feedback is greatly appreciated. We do use it to inform future events, so please fill that out for us. Archived presentations and a list of upcoming events can be viewed on our website. And if you experience any technical difficulties during this presentation, please contact updates@hcet.org at the email listed on your screen, or you can send me a direct message via the chat as well. And now I'd like to introduce you to your presenter for today. Dr. Jason Zucker serves as Assistant Professor of Medicine specializing in infectious diseases at Columbia University Medical Center. Concurrently, he holds the position of Assistant Medical Director at the New York City STD Prevention Training Center. Dr. Zucker's clinical expertise spans both adult and pediatric infectious diseases, with a particular focus on HIV prevention, and comprehensive sexual health care. In his research endeavors, Dr. Zucker integrates data, behavioral, and implementation sciences to enhance engagement in the sexual health continuum of care for individuals affected by or at risk of STIs. Notably, he serves as co-vice chair for the National Institutes of Health-funded study of Mpox for human Mpox virus, a pivotal clinical trial assessing Mpox's safety and efficacy. Dr. Zucker is also a co-investigator and site principal investigator for the CDC-funded Life After Mpox study and several other CDC Mpox initiatives. He has contributed significantly to clinical guidelines through his co-authorship of the New York Department of Health's AIDS Institute Guidance on Mpox and Advisory Committeeship on Immunization Practices for Mpox. And without further ado, I will be turning things over to Dr. Zucker.
Morning, and thank you for the wonderful introduction, and thank you everybody for joining us today. Oh, sorry, it wouldn't let me share for a second because you were still, there we go. All right. So welcome everybody. I'm gonna talk about Mpox, where are we now today? And I wanna be clear that we've really learned a lot. It's amazing to think that it was really June 2022, so just a little over 2 years ago that this all started, and sort of take you on the adventure from where we started to where we are now. Please feel free to interrupt at any time, ask questions using the chat or the Q&A feature, or I guess the Q&A feature, and I'll try to answer them as we go. The objectives for today are to really explain what we knew about Mpox before the 2022 outbreak, so you know where we started from, and you know what you'll see if you look at a textbook. I'll describe a little bit about what we learned about testing, treatment, and vaccination during this outbreak, and I'll summarize what we still need to know, which is quite a lot. We'll start with epidemiology and transmission. Prior to the 2022 outbreak, we didn't know that much about Mpox. We knew it was a double-stranded DNA virus with two clades. It had a pretty limited geographic region, most commonly in the Democratic Republic of the Congo. There'd be sporadic outbreaks. Every now and again, you'd see an outbreak in another country, but they were usually pretty limited. There was really limited human-to-human spread that was frequently constrained to households. That really all changed in June of 2022 with the start of the multinational Mpox clade 2 outbreak. Since that time, the first case was diagnosed in England in early May, first case in the US diagnosed in Boston in June. And it's hard to believe it's really been just over 2 years since that first case. But what was once an endemic disease has become a worldwide outbreak, with over 98,000 cases and counting in 115 countries as of July of this year. 111 of those countries, this disease is non-endemic in, like the United States. However, what you can see is that this is not happening over time slowly. In fact, the vast majority of the cases occurred in the summer. And you can see here the epidemiology curve of 2022, where we were at one point over 600 cases per day being reported. And what you saw was a rapid increase in the summer of 2022, followed by a rapid decline, and then an ongoing smattering of cases. We'll talk a little bit about what data we have on that coming up, but this is the 2022 data. You can see that the y-axis goes all the way up to 700 cases per day. By 2023, the y-axis only goes to 15 cases per day. But what you can see is that we're having sustained transmission. We're seeing ongoing transmission of Mpox almost every day, but much lower than we did of June of 2022. The CDC, the Mpox group is no longer tracking cases per day. It's now being done by a different group. So we don't get these nice charts, but we're getting approximately 50 or so, 50 plus cases a week, or 200 to 250 cases per month. And that's been pretty consistent over the last 6 months to a year. So while we're no longer seeing 600 cases per day, we are seeing cases every single day with 200 to 250 per month, meaning it's really important that we as providers, DIS, nurses, community organizations really keep Mpox in the front of our mind, remind patients about vaccination and testing, because it's not going away anytime soon. I want to touch just briefly on the clade 1 outbreak in the Democratic Republic of the Congo. Clade 1 is another type of Mpox. It had been previously thought to be more transmissible and cause more severe infections than clade 2. While the world has been dealing with this clade 2b outbreak, there actually has been a sustained clade 1 outbreak in the DRC that's now starting to cross borders there. Since January 1st of 2023, there have been greater than 20,000 suspected cases and greater than 1,000 deaths, a mortality rate of about 5%. It's important to know that clade 1 has not been reported in the United States yet. And so I highlight this just to let you know, because this is what you'll hear a lot about on the news. And while we're keeping and tracking clade 1, we have not seen any cases in the United States to date. It is a very similar virus to clade 2 in terms of the vaccination will be the same when we talk about vaccination. Treatment will be the same when we talk about treatment. In terms of transmission, whenever I talk about transmission, I get all sorts of questions about, can I get Mpox on the bus or subway, the grocery store, clothing store, gym, salon, or classroom, or any other place that I go frequently? And the answer is probably not. There are 3 transmission routes: animal to human, which is how we think a lot of these outbreaks start; fomite, or objects like linen sheets, to human; and human to human. In addition to those transmission routes, it can also spread via the percutaneous route, the mucosal route, or respiratory route. And that's important because when we see patients in the hospital with Mpox, the current CDC recommendations are to wear a gown, gloves, eye protection, and N95 respirator. Now, I'm going to highlight that not all of these are equal methods of transmission. And so while I'll never tell you to not follow the CDC recommendations for transmission, it is really important that we understand which ones are at higher risk of transmitting, so we know what we should counsel our patients on. In the real world, Mpox is occurring among a small group of people. And that's via, a small group of people. And in the real world, we're really seeing only one primary method of transmission, and that's via close human-to-human contact. Our amazing colleagues doing contact tracing, both in Europe and the US, figured out very quickly by early 2020 or mid 2022 that among Mpox cases with available data, 99% occurred in men, 94% of whom reported recent male-to-male sexual or close intimate contact, and racial and ethnic minority groups appear to be disproportionately affected. What's amazing is we figured this out very quickly after the outbreak started, but this finding continues to hold up as the outbreak continues. Additionally, there was a lot of suspicion that transmission was occurring primarily during sexual contact between gay, bisexual, and other men who have sex with men. And that actually fits with what were the unusual presentations we were seeing, with high rates of genital, rectal, or perianal lesions, often as the presenting symptom. This is a substantial departure from the classic presentation of Mpox, which was really defined by the rash on the skin, not necessarily in the genitals, anus, or perianal area. Now, I'm not going to get into whether Mpox is or is not an STI, but we do know that it can certainly be transmitted during the close physical contact that occurs during sex. What is also important scientifically is that there is an anatomic association between sexual practices and lesion location. The rates of proctitis or rectal pain are 5 times higher among those engaging in receptive anal intercourse than those not engaging in receptive anal intercourse. And so we know that the close physical contact that occurs during sex has really been the primary driver during this outbreak. Now, we can further support that you really need close physical contact by looking at some of the healthcare data. At a healthcare facility in Colorado, there were actually 313 people exposed to Mpox prior to the diagnosis being made. In many of these cases, the diagnosis was not even suspected, and complete PPE use was only 23%, and only 12% received post-exposure prophylaxis with vaccination. All 313 people were monitored for 21 days, and none acquired Mpox. Additionally, there's a great systematic review looking at healthcare workers and cases of nosocomial transmission that found that Sharp's injury, or sticking yourself with a needle that had been used to unroof a lesion, was the most common route of acquisition among cases reported. This is a great reminder that we should not be unroofing lesions, but also demonstrates that this disease is not that easy to transmit. I also want to talk about respiratory transmission. I mentioned respiratory as one of the 3 modes of transmission, but I also said that during this outbreak, close physical contact is really the primary driver of transmission. This review done by the CDC really demonstrated that actually, based on the available evidence, the likelihood of human-to-human Mpox virus respiratory transmission appears to be low. However, studies should continue to assess this possibility. Again, while not impossible, the primary driver of this outbreak really is close physical contact. I always like to tell people I'm based in New York City, and many of my patients came to see me on the subway. If respiratory transmission was a major driver of transmission, we would have seen more outbreaks among the general population traced back to riding the subway. And so I don't think that respiratory transmission is a major driver of this outbreak. So while transmission is possible in all 3 ways, it's clear that the vast majority of cases are caused by direct contact with infected lesions or body fluids. We also know that fomites, particularly soft porous items like linens, sheets, or towels, can transmit virus. It has been reported, but it's much rarer. And that while theoretically contact with respiratory secretions can be a route of transmission, it likely requires prolonged face-to-face contact, and we don't have any evidence of outbreaks via that route. However, what we do have evidence of is pre-symptomatic transmission, or we learn that it's possible to transmit Mpox before symptoms even start. That's important because it may explain why this outbreak increased so quickly, because patients didn't know that they had Mpox yet and were spreading it to others. In this prospective cohort study, they found that in 5 of 6 couples, 83.3% of definitely infected cases with a typical presentation, viral DNA was detected 1 to 4 days before the onset of any symptoms. Again, people are able to spread before they have symptoms, which is really important when we provide counseling to patients who may have been exposed. Additionally, this was a study that looked at contact tracing, and they identified pre-symptomatic transmission that likely occurred in 5 of 18 pairs, or the red ones listed here. And so again, while transmission is via close physical contact, it likely can occur in the pre-symptomatic phase, which makes sense and may explain how this outbreak spread so quickly. So we learned that rapid worldwide spread with substantial human-to-human transmission via sexual networks is possible with Mpox. We learned that respiratory transmission is extremely unlikely, and that pre-symptomatic transmission is both possible and does occur. We still have a lot to learn, though. How does the route of transmission impact the presentation or severity? Are there routes that are more efficient for transmission? Is receptive anal sex more efficient than close skin-to-skin contact, or are they the same? Does respiratory transmission play any role? And if not, can we stop having providers wear N95 masks? Because we've received feedback from patients that it's very isolating. And what are the long-term sequelae of Mpox? So next, I want to talk a little bit about presentation. How are patients presenting with Mpox? So prior to 2022, we really didn't know a lot. We knew that the mortality of clade 1 was around 5 to 10%. The mortality of clade 2 was less than 1%. And we knew from data from 1981 to 1985 that pediatric and pregnant persons had worse outcomes. I'm suspecting that there are people on this call who were not even alive in 1981 when that study was done. And so we had very limited data on Mpox. We knew about the classic presentation. This is the type of thing that would be tested on a board and an ID board exam, or if you looked up Mpox in Wikipedia, you would see. The disease typically started with a viral prodrome, similar to many viral illnesses. This included fevers, chills, headache, malaise, myalgias, and lymphadenopathy. After the prodrome, patients would usually develop a rash. It most often occurred before day 5, most frequently on days 1 to 3. These rashes are firm, deep-seated, well-circumscribed, and sometimes umbilicated. Remember, we said during this outbreak, a lot started in the genital and perirectal area, but traditionally they would start on the face and spread to the extremities, including the palms and soles. They would typically progress through several synchronized stages, meaning that all the ones on the arm would progress together through different stages. They could be extremely painful and last for up to 4 weeks. This is a slide that sort of shows the traditional Mpox virus timeline. It starts with an incubation period of 5 to 21 days, meaning that after an exposure, it can be up to 21 days before you have any symptoms, although for most patients, it occurs around day 6 to 7. That's followed by the prodrome we described earlier, with fever, feeling tired, headaches, sore throat, cough, and swollen lymph nodes, followed by nenathum, which are lesions that start in the mouth. Let me get my laser pointer, there we go, start in the mouth. During this period, you could have infectious virus in your mouth that can spread through kissing and oral contact before you may even realize you're infected. That's followed by macules, which are flat lesions on the skin. Because they're small and flat, they can be very easy to miss. That's followed by papules. Papules are solid and superficial, not yet fluid-filled. They're generally less than 1 centimeter in size and can look a lot like acne. They can then progress to vesicles. Vesicles are still small, usually less than 1 centimeter, and filled with a clear, clear fluid. The vesicles can progress to pustules, which are filled with a darker fluid, more consistent with pus. They can also become umbilicated in this stage, developing a hole in the center, which is very classic for orthopox viruses like Mpox. After that, they start to scab. And it's important to know that the scabs are actually still infectious. Patients are not considered fully resolved and no longer infectious until the scabs have fallen off and there's new, fresh skin underneath. However, while that's the typical presentation, that's not how it's presenting during this outbreak. During this outbreak, the rash could be the presenting symptom, but it can also occur before or after the prodrome. The prodrome is not always first. Second, while we're going to talk about a lot of other symptoms, the rash is still common and occurs in greater than 95% of all patients. The caveat to that is that the rash will not always be first. Patients may present with other symptoms before developing the rash. The rash can also have multiple lesions in different stages on the same body part, so it's not progressing in a synchronous fashion. We're seeing high rates between 50 and 75% of patients presenting with genital and anal lesions. Proctitis is a new and very common symptom, as much as 40% in some case reports. It's often the presenting symptom with these deep ulcerative lesions seen when examined via sigmoidoscopy. Urethritis presenting with dysuria or painful urination have also been reported, and you can see here this patient has Mpox lesions in the penis, but it would be very easy to confuse the dysuria of Mpox with other sexually transmitted infections if they don't do a close exam or they don't have lesions other places in their body. Pharyngitis has been another common presentation with mouth and throat lesion seen, and actually at our site has been one of the #1 reasons for admission to the hospital because it's been so painful they've been unable to tolerate anything by mouth. Ocular disease from either direct inoculation or auto-inoculation has been reported. This has also been reported in the DRC, and ocular Mpox can be a sight-threatening condition. Lymphadenopathy has always been associated with Mpox. However, lymphadenopathy often in the region of their lesion, so in the sort of groin and inguinal area for genital lesions and rectal area for anal and perianal lesions. And these can be pretty significant. In fact, this patient said it felt like he was walking in with a fanny pack, and he was having a hard time walking because the lymphadenopathy was so large and so painful. Finally, in large part because of the locations of the lesions, we're seeing multiple episodes of bacterial superinfection. These open lesions getting infected with skin flora, making them worse. This is particularly common in patients who maybe seem to be improving, but then have a worsening of the pain or worsening of their lesions. And these are just some of the many common ways Mpox is presented during this outbreak. Now, most of these people, or almost all of these people, will actually get better. What's really most important is that the mortality has been well below that 1% figure we had before. There have been over almost 31,000 US cases with less than 60 tragic deaths, meaning the overall mortality, 32,000 cases with 60 US deaths, meaning the mortality has been 0.18% or 1/5 of the 1% estimated. With that said, the vast majority of deaths for people with severe Mpox have been people who are immunocompromised. In this outbreak, that has mostly been people with HIV. You can kind of see this on the chart on the right. Each of these is a different system, so dermatological, respiratory, ocular, gastrointestinal, etc. The orange line are individuals with CD4 counts less than 100. And you can see that they have many more complications than those individuals with CD4 counts 100 to 200, which is the lavender or purple line. Less than those with CD4 counts 200 to 300, which is the blue line. And less than those with CD4 counts greater than 300, which is the green line. Mpox really takes advantage of the immune system, acting like an opportunistic infection. We talked a little bit earlier how close skin-to-skin contact is one of the drivers of Mpox transmission. This was a case report that we did along with Emory and the NIH that really looked at skin biopsies of patients with persistent Mpox in spite of medical countermeasures and all the treatment we could offer them. And what they found was that in the skin, there was abundant replication of Mpox virus in epithelial cells and dendritic cells. The data suggests that prolonged Mpox in people with advanced HIV is actually due to ongoing viral replication, which really warrants aggressive medical countermeasures and immune optimization. Said more simply, these patients can have viral replication in the skin for a long time, meaning that they're contagious for a very long time, and also at ongoing risk of bacterial superinfection and other complications. But it's not just the skin lesions that complicate immunocompromised patients. In another report from the CDC, they actually found Mpox virus on autopsy in the lungs, lymph nodes, spleen, liver, and adrenal gland. And so it really can spread throughout the body, causing severe illness and even death. And so just like we said in the skin, on pathology and autopsy, severe Mpox in immunocompromised patients is characterized by extensive viral infection of tissues throughout the body that can progress despite available therapeutics. The GI tract and lung were the most commonly involved areas. Because of that, we did add guidance to the opportunistic infection guidelines on Mpox. And it's important to know that when we talk about immunocompromised patients, while the vast majority are people with HIV, there have been case reports of other immunocompromised persons having complications, including renal transplant recipients. We're going to talk a little bit later about available therapeutics, but it's important to know that for these people with advanced immunosuppression, in New York City, we described how despite extended treatments of all the available agents we're going to talk about today, individuals who are severely immunocompromised experience prolonged hospitalizations and high mortality, really highlighting the importance of, one, helping reduce immunosuppression wherever you can, so helping patients living with HIV to take their medications, but also the importance of vaccination to prevent infection. As a med-peds physician, I was extremely worried about the implication for children. Going into this outbreak, the data we had from Africa suggested the disease may be worse in those 8 and younger, with higher mortality in the younger age groups. Additionally, in 2003, there were about 57 US cases associated with a prairie dog outbreak. 29% of those were pediatric patients, and those patients were more likely to end up in the intensive care unit, suggesting that pediatric patients may do worse with this disease. However, luckily, that's not what we've seen so far. There have been relatively few pediatric infections and a relatively low hospitalization rate with no deaths. One thing that's really interesting is just the difference in transmission patterns. I mentioned before that we really saw a lot of household transmission in the Democratic Republic of the Congo. And in fact, in their ongoing studies, the majority of people enrolled are actually pediatric patients. So we'll likely gain more information about clade 1, but we don't have as much about clade 2 because we've just not seen as much transmission among households and children in the United States. Additionally, data on pregnancy was extremely limited. The literature before 2022 had a total of 5 lab-confirmed cases, 3 which resulted in fetal loss, with Mpox virus identified in fetal tissue and placenta, demonstrating spread in utero. While maternal outcomes were okay in these cases, there were additional concerns because smallpox virus is associated with more severe illness during pregnancy for mothers. The data on pregnancy during this outbreak remains limited. The CDC put together a series that included 23 Mpox cases. 4 pregnant persons required hospitalization. 11 received tecovirimat with no adverse reactions reported. But we still have limited published pregnancy outcomes with only 3. 1 with a spontaneous abortion and 2 successful uncomplicated deliveries. The WHO site lists 54 cases in persons who are pregnant, but does not have any outcome data reported. Again, it's important that we understand what the implications are for pregnant persons who may acquire or be vulnerable to Mpox. So what we learned since the start of the outbreak is that most patients who are non-immunocompromised recover without significant complications. We saw that pediatric patients without notably worse outcomes, and we saw that immunocompromised patients, particularly those living with HIV, had the potential for a severe necrotizing form of disease, worse outcomes, including death. We still need to know a lot more. What is the pathology or pathophysiology of why immunocompromised persons have worse outcomes, and what can we do about it? Does Mpox lead to immune reconstitution syndrome in persons with HIV and low CD4 counts, and how would we manage that? So we've talked about epi and presentation, but now let's talk briefly about diagnostics. Val, to answer your question, the Mpox in pregnancy cases, the 5 from years ago were from clade 1. The recent ones I described from the CDC and WHO where we don't have outcome data were clade 2. So in terms of diagnostics, before the outbreak started, orthopox PCRs were available only at lab response network labs and could only be run on lesional swabs. We've since learned that Mpox DNA has been identified in many other areas: seminal fluid, rectal swabs, urethral swabs, respiratory secretions, as well as blood. However, with that said, you can quickly see that we learned it's not the same at all sites. Here, CT values are used as a surrogate marker of viral load, and lower CT values represent a higher viral load. The highest viral loads are seen in the skin, followed by the anus or rectal swabs, then throat, blood, urine, and semen, really suggesting that skin may be one of the best sites to make the diagnosis due to its high viral load. Furthermore, this is a study from Spain that looked at viral loads and time to clearance. As you can see in the chart here, the time to clearance of patients in blood, semen, rectum, and pharynx was over a week faster than those of lesions. So not only does skin or skin lesions have higher viral loads, but they stick around longer, making them really great places to make the diagnosis. However, what you don't see here is that while most symptomatic patients will develop skin lesions, we know that skin lesions may occur after the start of symptoms like pharyngitis or proctitis, so waiting for skin lesions may delay making our diagnosis. As far as I know, there's at least one academic lab that has validated testing of other sites other than skin lesions. But so far, all of the commercially available EUA test kits only include PCRs from lesion swabs, and these are now being done at local labs, the major commercial labs, as well as public health labs. But we still really need to think about if current diagnostics are enough. What about when patients are asymptomatic? So if they're symptomatic, we know what we can do, but what about asymptomatic patients? I mentioned earlier that patients can have pre-symptomatic disease, but what about asymptomatic, meaning they never develop any symptoms? Well, in this study out of Belgium, they retrospectively screened 224 samples that were collected for gonorrhea and chlamydia testing and found that 3 rectal swabs and 1 pooled sample were positive for Mpox. 3 of the 4 never developed any symptoms suggesting asymptomatic disease, and all 3 had positive serology, 2 of which had culturable virus, really suggesting the possibility of ongoing transmission. And so testing of non-lesion body sites may have a benefit in identifying pre-symptomatic or asymptomatic disease. And in fact, in New York City, they did a serology study and found that 1 in 15 vaccine-naive people had antibodies to Mpox during the height of the New York City outbreak, indicating the presence of asymptomatic infection that could be contributing to ongoing transmission. And so we learned that orthopox testing of skin lesions could be scaled up quickly at commercial labs. We learned that pre-symptomatic and asymptomatic disease both occur, and that testing other body compartments like the pharynx or rectum could allow for earlier diagnosis, but there's no commercially validated assay for that. What we really do need are commercially validated assays from other body compartments. And then what I think is the most important is a multiplex lesion PCR that would test for not just Mpox, but HSV, VZV, syphilis, and other similar diseases. Especially as cases have gone down and Mpox has left the center of our minds, we're seeing more and more missed opportunities for earlier diagnosis. So now on to therapeutics. Prior to 2022, we did have tecovirimat approved for smallpox via the animal rule and available through an expanded access investigational drug application. The animal rule is something that's available for approval of drugs where it would not be possible to conduct a clinical trial. So for example, it would not be possible to conduct a clinical trial of smallpox in humans because smallpox has been eradicated. But it's also important to have drugs for smallpox because there's always the concern about being a weapon of bioterrorism. And so the FDA has this method through the animal rule of using similar viruses like Mpox and animal models to approve drugs, and that the only human data is safety data. And so tecovirimat was approved through this mechanism. So meaning there is no human efficacy data in people with Mpox for tecovirimat prior to 2022's outbreak. Vaccinia immunoglobulin which is immunoglobulin to vaccinia, had some benefits for people with disseminated vaccinia, but no data in Mpox. We knew that there was in vitro synergy between tecovirimat and another drug called brincidofovir. And there was some concerns about tecovirimat having a low barrier to resistance if we were to use it a lot. So I started earlier by saying that mortality is much lower than expected, and that most patients will fully recover. There is an ongoing study called LAMP, or Life After Mpox, that was just presented. The data was presented at AIDS 2024 in Berlin, but to try and help us understand how patients recover. What's important, though, is that most patients really only need supportive care because they'll fully recover on their own. Supportive care includes things for symptomatic treatment, and the CDC has put together clinical considerations for pain management of Mpox, which really is the #1 complication patients are having. For proctitis, this includes things like stool softeners to make going to the bathroom easier, sitz baths, topical agents like lidocaine gel, anti-inflammatory medications, and prescription medications like gabapentin and opioids if the pain is really severe. For pharyngitis, it's similar. Saltwater gargles, viscous lidocaine, and magic mouthwash are all topical agents that can help. Oral antiseptics can reduce the risk of infection, and anti-inflammatory medications and opioids if needed. For genital lesions, frequent bathing and keeping them clean and dry, and if infected, wet to dry dressings, and topical and systemic antibiotics. Next are medical countermeasures. And I actually kept it because they recently updated the CDC IND for who meets criteria for medical countermeasures. And it's currently individuals with severe disease or individuals who are immunocompromised or at risk of severe disease. I've kept a previous version here because most people were using that one to treat people with things like tecovirimat. It's important to know that it's no longer included. Involvement of anatomic areas which might result in serious sequelae like rectal pain or pharyngitis are no longer indications for medical countermeasures because they were not seeing complications from them. While supportive care works for most patients, some patients with severe disease or at risk of severe disease really do require medical countermeasures. And for severe Mpox, Dr. Agam Rao from the CDC put together a wonderful review with interim treatment recommendations and an excellent flow chart that provides the best guidance possible. The recommendation really is to consider more than one therapy for patients who are severely immunocompromised, like our patients living with HIV and low CD4 counts. The first medical countermeasure we'll talk about today is vaccinia immunoglobulin. It's available through an EA IND from the CDC. And there's some evidence of benefit when used in cases of progressive vaccinia. We have very little data on it, on its use in Mpox, although it has been given to people who are severely immunocompromised and are unlikely to mount their own immune response. In terms of antivirals, there are 3 systemic and 1 topical that I'll review. The first thing I always want to highlight is that orthopox viruses are not herpes viruses. So things like acyclovir and valacyclovir are not going to be active. However, both cidofovir and brincidofovir are potential agents. Cidofovir diphosphate is a competitive inhibitor, an alternative substrate for DNA polymerase. It gets incorporated into the growing DNA strand and blocks further replication, leading to non-productive infection. However, given the low overall mortality of this disease and a significant risk of renal injury with cidofovir, this drug has rarely been used except in severely immunocompromised individuals. Brincidofovir is actually a similar drug, but has a side chain that gets cleaved, releasing cidofovir, so it's thought to have less renal toxicity. For brincidofovir, prior to this outbreak, we really just had this case series from England. The first 3 patients treated with oral brincidofovir after the onset of rash. All 3 patients developed elevated LFTs or liver function tests, and none completed treatment. With that said, we've been using it a lot more in immunocompromised people during this outbreak, and the liver function test abnormality has not been seen that frequently. Secondly, cidofovir has been used both topically and injectable, where you have less of the renal concerns. This was a case out of Emory, where this patient had 3.5 months of treatment, and it was just intractable disease. They ended up using intralesional cidofovir. This is done in concert with dermatology, who can both mix the intralesional cidofovir and inject it. And they had this dramatic improvement, which finally allowed the patient to be discharged. This resolution actually continued without recurrence over 2 months later. Finally, the last drug we'll talk about today is tecovirimat, which has really been the go-to treatment of the Mpox outbreak. I mentioned earlier that tecovirimat was approved through the animal pathway. And so actually, efficacy was done entirely through animal studies. And this is the human safety study that led to its approval. 359 healthy patients with only one serious adverse event that was not attributed to the drug. In terms of efficacy prior to this outbreak, there was this one paper, the same one that included the patients who got brincidofovir earlier. They had one patient treated with tecovirimat with no adverse effects and appeared to have a shorter duration of viral shedding and illness. However, one patient is really more anecdote than it is evidence. And while there are a few other case reports, we've been gaining more evidence through the course of this outbreak. We're also learning a lot more. How do we dose tecovirimat? This was a study out of Italy that demonstrated lower than expected plasma concentrations in persons with HIV and Mpox. Is tecovirimat safe? Well, we have a lot of data now. As of August, when reporting ended, tecovirimat had been prescribed to almost 8,000 persons during this outbreak. So far, we just have this first safety study that only had 174 patients with both intake and outcome forms, but they only reported 12 adverse events, of which none were labeled as serious. As I said, they've given tecovirimat to over 8,000 persons during this outbreak. And I suspect we would have heard if there's a substantial safety signal, given the number of patients that have received this drug. Probably the most important question is, does tecovirimat work? And observational data is mixed. There's 2 studies that suggest that maybe it works if given early, as well as studies that suggest that it didn't have any effect in shortening healing time or viral illness, and was not associated with faster illness resolution, but that it may hasten subjective symptomatic improvement. At the same time, there's also concern about tecovirimat leading to resistance. There are several studies now with similar findings. This is a CDC one, which is with a larger case series. And they found that in severely immunocompromised patients with multiple courses of tecovirimat, they developed resistant phenotypes. What they really demonstrated here is that tecovirimat specifically selects for resistance, where similar mutations in individuals not receiving tecovirimat have generally remained phenotypically sensitive. With that said, there's also been reports of transmitted resistance, meaning people acquiring Mpox that's already resistant to tecovirimat, including 11 cases in a Southern California outbreak tracked back to I think a music festival. What this really leads me to is that we need a clinical trial. We still don't know if tecovirimat works to treat Mpox. There's no human data that confirms that tecovirimat is effective in treating Mpox. We need to better understand the potential for Mpox to develop resistance to tecovirimat. And patients deserve treatments that work. If tecovirimat is not effective, we need to search for a new treatment. If tecovirimat is effective, we need to ensure that people with Mpox have access to it. And so with that, I'll highlight the STOMP trial, of which I'm one of the vice chairs. You can refer patients to this trial, or they can call themselves, but virtually anybody with Mpox and less than 14 days of symptoms are eligible. We have randomized arms that are 2-to-1 drug to placebo for most patients, and an open label arm for children, pregnant or breastfeeding people, and those with severe disease. If you're looking to access medical countermeasures outside of clinical studies, you can find more information at this site, cdc.gov/poxvirus/mpox/clinician/treatment, but I'll make the slides available. And it has information on all of the EIND and EAIND programs, as well as the email address and phone number for a CDC consult to get access to these medications. So sadly, we've really not learned enough. We did learn that tecovirimat is likely safe. We also learned that tecovirimat selects for resistance in patients with prolonged infections, and that transmitted resistance can occur. We still really do have a lot to learn about treatment. Does tecovirimat work? Does cidofovir or brincidofovir work? What is the role of VIGIV? And what is the best treatment or treatments for our immunocompromised patients? Finally, our last section on prevention and vaccination. At the start of the outbreak, smallpox vaccine for Mpox was thought to be about 85% effective. And we did have an approved vaccine in the MVA vaccine that was available only through the Strategic National Stockpile, or SNS. I want to start with what we learned about the community that we serve. A community that had also just gone through COVID and was going through a second major outbreak in a short period of time, and really credit them for the incredible resiliency they showed here. In spite of everything at the start of the outbreak, patients adjusted their sexual behaviors to prevent Mpox. Over half decreased their number of partners, decreased one-time sexual encounters, decreased sex with partners met on apps or sex venues, decreased group sex. Behavior change is not and never should be permanent. We strive to be sex positive, but behavior change can be an important bridge to something else. And in this case, that bridge is vaccination. Data from the UK suggests that, at least in this context, the outbreak was actually initially controlled by the adoption of self-protective behavioral changes undertaken by populations disproportionately affected by Mpox, and that vaccination efforts were instrumental in consolidating and preserving that progress. So we can use vaccination in two ways to prevent Mpox. It can be used for post-exposure prophylaxis, where it should be given as soon as possible after exposure, generally within 4 days to prevent disease, 4 to 14 days to reduce symptoms. And for those who are immunocompromised and exposed, you could consider vaccinating immunoglobulin for patients who may not be expected to mount an immune response to vaccination. For pre-exposure prophylaxis, we're going to come back to this, but it has been traditionally recommended for clinical and research lab workers, public health response team members, and now during this outbreak, epidemiological risk groups. I want to start by talking about the limited data on PEP that we do have. We really just have this observational study that was conducted emulating a nested target randomized trial. They did two analyses, a traditional multivariable regression and a target trial emulation. And they found that in the traditional analysis, PEP was 78% effective, but only 19% using more advanced statistical techniques. And so we really have limited data on the effectiveness of PEP. However, for pre-exposure prophylaxis, we do have an approved vaccine. And so randomized trials would likely not be feasible. And so we're really left with observational data. But I think it's clear from this chart that vaccination does work to reduce infection, with one dose efficacy ranging from 36 to 86%, and two doses 66 to 89% efficacy. Vaccine doesn't just reduce infection, though. It also mitigates disease. And this study out of California actually demonstrated decreased hospitalization after Mpox vaccination. I mentioned that the indications for vaccination for PrEP now include epidemiological risk groups, and those are the ACIP recommendations. The ACIP recommends vaccination with the two-dose series for persons aged 18 years and older at risk for Mpox as defined by gay, bisexual, and other men who have sex with men, transgender and non-binary people who in the past 6 months have had one of the following: a new diagnosis of an STI, more than one sex partner, sex at a commercial sex venue, sex in association with a large public event, sexual partners of persons with the risks described above, and persons who anticipate experiencing any of the above. I'll also say that the ACIP recommendation is only for those age 18 and up. However, at the same time, there is an EUA allowing for vaccination for those less than 18. And we have routinely vaccinated people 15, 16, and 17 with these same vulnerabilities to Mpox. In terms of special circumstances, previous smallpox vaccination does probably provide some protection, but it may not be lifelong. And vaccination should be given to eligible people who were previously vaccinated against smallpox. Pregnancy is not a contraindication to vaccination, either as PEP or as PrEP. And individuals previously infected do not require vaccination, as Mpox infection confers additional immune protection. They do say there's one caveat: an immunocompromised person who's diagnosed with Mpox after their first dose may receive a second dose on a case-by-case shared decision-making basis. However, I'll say the CDC has discouraged vaccinating those who have already had Mpox, as the immune response is fairly robust. One of the biggest questions coming out of the past year has really been about reinfection and post-vaccination infection. And we're starting to see scattered outbreaks, generally post-vaccination infection, and rare reinfections. This study looked at persons who had both prior infection or complete vaccination and post-vaccination infection. And they found that those people had less severe disease, fewer lesions, diminished mucosal involvement, reduced analgesia requirements, and fewer admissions. So it's clear that there's protection from both vaccination and prior infection, and that even when infected, individuals have less severe disease. Vaccination can impact presentation. This was a study done at the University of Washington that actually looked at patients who were coming in for sexual health care. They found that 1.1% of patients tested during almost 1,700 visits had asymptomatic or subclinical Mpox, making it extremely uncommon, and that those who were vaccinated were more likely to have asymptomatic Mpox. Again, vaccination likely reducing the severity of disease. This slide is really just to indicate that we don't know the answer yet, and we don't know how long protection lasts. Currently, there's no recommendation from the CDC or other groups to repeat a third dose of vaccination, but there's a lot of ongoing studies monitoring antibodies and the cellular response to vaccination to help us better understand if a further booster may be needed in the future. And so we learned that vaccination is effective in preventing and attenuating Mpox, but we don't know how long vaccination will last and if we'll need boosters at some point. We also don't know if persons who previously had Mpox will need to be vaccinated and when. Just to wrap it up for today, the 2022 Mpox outbreak was different. It changed a lot about what we previously knew about Mpox epidemiology, transmission, and presentation. We learned about rapid spread through sexual networks, severe disease in immunocompromised patients, pre-symptomatic and asymptomatic live virus identified. Tecovirimat is likely safe, but does lead to resistance, mostly in immunocompromised patients with longer courses, but transmitted resistance has been seen. Vaccination is effective for preventing or attenuating disease, and combined with behavioral change was a powerful combination at the start of the outbreak. The current Mpox outbreak started by spreading rapidly, can be serious, and cases are still ongoing, and we still have a lot more to learn. And with that, I'll stop and take any questions. Thank you so much for joining today.
Thank you so much, Dr. Zucker. If anyone has any questions, you can throw them in the chat. If you like the anonymous option, you can use the Q&A. And while folks think of questions, I'm also just going to put the evaluation for this webinar into the chat. Again, please fill that out for us. We really appreciate your feedback. Dr. Zucker, it looks like a question came in. Where can we find the link to the clinical trial?
Oh,
I'm happy
yeah.
to put that in the chat, or you can, whatever
Yeah.
works best.
There you go. We have a question. Burton asks how we're replenishing our stockpile of smallpox vaccine. We're kind of going the other way on that. They've actually commercialized the vaccine now. So it's now commercially available. So you no longer necessarily need to get it through the Strategic National Stockpile. The Strategic National Stockpile actually has a lot of vaccine and continuously purchase more as it expires. So that's not as much a problem, but it's now available commercially as well.
It looks like someone asked, is the Mpox vaccine the exact same as the smallpox vaccine?
So it is. It's not the same as the original smallpox vaccine, so I didn't go into the level of detail, but the original smallpox vaccine caused what's called a take or a lesion on your arm. That one would, if you do have that mark, you would have had it. And that can be used. And in the 1981 to 85 study, that was the vaccine that was available then. We currently in the US have two vaccines available, ACAM 2000, which is that one, and the modified vaccinia vaccine, which is not a live vaccine. During this outbreak, nobody in the country used ACAM 2000. They only used the MVA vaccine. And so that's the only one we talked about today. And again, if you've previously had the smallpox vaccine greater than 3 years ago, the recommendation is that if you're vulnerable to Mpox in one of those groups, you should get revaccinated.
I'll leave it open for another couple minutes if anyone has any lingering things, but if I just want to say too, if anyone thinks of anything later today and you think, oh shoot, I should have asked that, definitely feel free to send it my way. I can put my email in the chat and forward anything on to Dr. Zucker. Also, the PowerPoint slides are available to you, and I can include them in the thank you email that I send following this as well, if you want to refer back. Oh, it looks like the person that asked about the smallpox vaccine asked you to repeat because they had audio issues.
Sure. So Mpox and smallpox vaccines are the same vaccines. The one that we often think about with the lesion that becomes a lesion on your arm, what's called a take, are the first and second generation smallpox vaccines, and those are live vaccines. Currently in the US, there are technically two available vaccines, the ACAM 2000, which is a live vaccine that could be on your arm, that was not used at all during the 2022 outbreak, or the modified vaccinia anakinra, which is a non-live vaccine, which was the only one used during this outbreak. And so yes, that vaccine covers both Mpox and smallpox and other orthopox viruses. those of a certain age would have had vaccination, but as a reminder, if you've had vaccination greater than 3 years ago and you're vulnerable to Mpox and in one of those groups, the recommendation is for you to be revaccinated.
Someone anonymously asked in the Q&A, did we see a misdiagnosis of Mpox as syphilis early on due to the presence of a palmar plantar rash?
Not just early on, we are still seeing it very regularly. So I think, the Mpox can look like syphilis, it can look like molluscum, it can look like HSV, VZV. And so we see a lot of misdiagnoses with people thinking about things that used to be more common. And so it's really important that we do comprehensive testing when we see one of these rashes, because I've seen 300 plus cases, and I still cannot tell you with complete certainty which is which.
Kevin in the chat also asked, is there testing for Mpox still?
Yes, absolutely. And we're encouraging people to test for whenever they're seeing these lesions, because again, there are 200 cases, 200 to 250 cases a month in the United States. So it's not as common. Yeah.
All right. Well, thank you again so much, Dr. Zucker. I really appreciate it. This was very informative. I know I learned a lot, and I hope you all did too. Like I said, if anyone has any lingering questions they think of later, you can email me at jmerch@hcet.org. If you forget that, you can also email updates@hcet.org. And I will be sending a email following this webinar with a link to the evaluation as well as the PowerPoint slides again. So, and I will follow up with you via email, Dr. Zucker. So thank you all. I really appreciate it and enjoy the rest of your day.
Thanks, everybody.